Buenas tardes, Buenas tardes, everyone. I will start by introducing my esteemed panelists that we have today. We have with us Abhimanyu Saxena, who is the head of health system strengthening at UNDP India. Abhimanyu has more than 15 years of experience in immunization supply chains. He's an engineer and MBA by education. He has led the implementation of even COVIN and UN systems in India. Besides that, he has done digitalization projects in Indonesia, Sudan, and Malawi. We also have with us Stefano Malvoltis. He's the co-founder of MMGH Consulting. Stefano has more than 25 years of experience in diverse areas: vaccine policy, epidemiology, strategy, forecasting, and the list goes on. Uh, Before MMGH, he was the CEO of Univac and also the director of vaccine implementation at Gavi. Besides holding positions in Baxter, Path, Novartis. By education, he is a Master of Public Health and Master of Business Economics and has published several papers in the area of immunization. So please welcome our panelists. So you might have noticed that Abhimanyu is not here among us, but we have a digital solution for that. So in eight minutes time, hopefully he will appear amongst us. Okay. So let me start by saying that, once upon a time and not very long ago, digitalization was simply digitization of stock and immunization data. I mean, that's all it was. We had all sorts of physical forms. We had bin cards, stock registers, request and requisition forms, and the idea was to get them into an electronic form and report them. I think now we have come a long way from that. Digital solutions today can do really a lot more than that. They can really strengthen and improve the supply chain and solve a lot of problems. So, uh, in this session today, basically, we have three objectives. First is to make you believe that supply chain, immunization supply chain can be digitally transformed. Second is through country examples. We want you to take some learnings, how this can really be done very effectively. And third, we want you to go back to your countries and digitally transform the supply chains back in your countries. So let me start by talking about four key needs. You can call them needs, you can call them problems, call them challenges that immunization supply chains are facing these in today's context. So at the very start, all this focus on zero dose, equitable coverage. Uh, the first thing that we need is availability of stock, and for that we really need to track and trace the stock as it moves across the supply chain. We need to have very good visibility, especially at the last mile, or at least the district level, for us to be able to do that. So that is one definitely very important need. Second is, as Gavi transitions out from more and more countries, as countries get into co-financing, as more and more expensive vaccines are launched, and the resources always continue to be limited. So there is a lot more focus now, besides the availability part, on having supply chain efficiency and reducing waste. Thirdly, with the threat of pandemics, with more and more natural disasters because of climate change, because of more and more conflicts around the world, we need the supply chains to be more and more resilient. We want them to be also flexible and adaptive at the same time. And lastly, with introduction of new vaccines, new device delivery, increased volume of vaccines, there is a much more larger scale and complexity that we need to deal with. On the other hand, we have also seen emergence of certain digital technologies, and I would say emerging or emerged already in the last few years. And the first is web and mobile technologies. I don't need to explain that. You're carrying it in your pocket right now. Uh, Another is automated data capture, and you would have seen all the wonderful RTMD solutions. So that's a very good example how you can automatically capture a lot of data. Other examples are user barcoding, and then there are a whole host of technologies through Internet of Things and sensors, which will also allow us to do that. Then uh, you would have seen there are many systems that are there as part of the digital ecosystem. You have got DHIS to HMIS systems. You've got ELMIS, EGA tool. You would have seen in the Innovation Cafe. forecasting tools, procurement tools. So we really need good interoperability standards and technologies, and that is what has also have been coming up. We have got open standards for interoperability, such as the fire standards, and then there are interoperability middleware, which are also emerging. And lastly, with all these systems and all the data that is being generated, we have a great opportunity to get into advanced analytics, to even get into artificial intelligence, make sense of this data, and use it to really improve and transform our supply chains. Now, between the chicken and egg, we don't know which came first. But between needs and technologies, the needs always come first. So the idea always is, if we see some exciting technologies, not to try and force fit it, but look at these problems that we have and see and map them to what technologies can be used to really solve these problems. So we don't have much time for me to get into the detailed mapping, but I'll just use some fancy slide animation to get through this more quickly. So 1, 2, 3, 4, and the spaghetti. So the basic idea, the message here is that a combination of these different digital technologies, these and many more which are there, can be used to, if not fully solve these problems, at least to a great extent, alleviate these problems, meet these needs a lot. Now, while that is important, I think the most important part is how we are able to deploy these technologies in these countries, how the countries are able to maintain the digital solution and sustain them. So in 2022, Gavi also came up with a digital scale-up strategy. So now what we are doing is, besides the funding and investments that we put in, we are also putting in some guiding principles to help the countries scope their digital projects, and basically get the maximum out of their digital investments and all the efforts that the countries put along with us. So to start with, of course, geographical saturation. So it's important for the digital solutions not to cover the different functions of the supply chain, but also the different locations, especially downstream at the district and at the service delivery points. Then we talk of course, interoperability. I talked about it in the last slide. Then data quality. It's not just about getting the data, but we really need good quality data to be able to effectively manage the supply chain. And once we get that good quality data, it is also important for using this data for decision making. Otherwise, the whole effort is really lost. Now, another aspect is, for long we have only focused on getting this data, getting good data, and making use of this data. Other potential that we also have from digital solutions is that they really help us to streamline the processes, streamline the workforce, get process efficiency out of in the supply chain. So that is another aspect that we should really focus on. Target software standards, which were first released in 2018, remain, and we just released version 2 along with our partners, Global Fund, BMGF, and USAID. And these help the countries to make sure that you have got best-in-class systems, and you deploy the best practices in terms of digitalization. There are also a few softer aspects. So we need to build sustainability into our digital projects right at the start. So there's no point doing a pilot or a rollout after 3 years, and then we find that the country is not able to transition and sustain it. Then strong leadership and management. So technology solutions are not something which some techies are going to do. It's very important for the leadership, management, NLWGs to really get involved in these digitalization projects. And lastly, integrations across the program. So we have been talking about smart integration and harmonization. And trust me, when it comes to supply chain integration, the easiest part is to integrate systems. We have in many countries one system, very well meeting the diverse needs of different programs, but there's just one solution under one management, under one sort of data repository. Integrating infrastructure, people, and processes is actually much harder. So this is the overall probably framework at a conceptual level. But really, what is important is for us to see how countries, and we'll see that many countries are actually using these, not just these principles, but also overall digital technologies, and really transforming the supply chain. So with that, we will get into the digital journey of immunization in India, and where you will see some of the things that we've talked about, how effectively they have used to transform their supply chain. So over to Abhimanyu.
Hello everyone, I am Abhimanyu. I head the Health System Strengthening Unit at UNDP India. And today it is my pleasure to talk about digital immunization journey of India from even to UWIN. And at the outset, I would like to thank the organizers for giving me this opportunity. So let me share my screen and talk more about this digital transformation. So, giving you some kind of a reference, we'll talk about even pilot and scale up, then its cost effectiveness, the techno-economic assessment. We'll talk about COVID and how it was utilized for individualized tracking of COVID vaccination in India. And now how we are leveraging uh, this platform for developing UWIN, which will be used for individualized tracking of routine vaccination for children and pregnant women in India. And then, what are the learnings of this entire process? So, just to give you some background, India has world's largest immunization program, wherein we have more than 27 million newborns every year for immunization. We have around 13 million pregnancies every year for vaccination. We have, if you talk about less than 5 years of age children, then close to 100 million of them for vaccination. For storing vaccine, we have more than 29,000 health facilities and what we call them as cold chain points. India procure more than 650 million doses every year, and we conduct more than 9 million immunization sessions every year. So, with these humongous numbers, there are three pillars. First, even electronic vaccine intelligence networks, which is there to digitize the immunization supply chain. Then in 2021, we started with COVID for the individualized tracking of COVID vaccination, wherein we register close to 1.1 billion beneficiaries and more than 2.2 billion doses were digitally tracked. And now leveraging this technology, Ministry of Health and Family Welfare, with support from Gavi and UNDP, is developing UWIN, which will be used for registering eligible beneficiaries, pregnant women and children up to 6 years, with real-time recording of pregnancy outcome and vaccination of beneficiaries. So, in terms of challenges which was there and how we managed to overcome those challenges when India started electronic vaccine intelligence network. There was a lack of real-time visibility for vaccine stocks and storage temperature. We all know there's a short shelf life for vaccines, and it's a biological product. There's not a standardization in the record keeping for vaccine stocks. There was a mismatch in demand and supply because we don't have the right visibility at the right time. And of course, it's not easy to have desktop computers and other equipment in all the remote health facilities. And India has a complex six-level vaccine supply chain from national store to state store to divisional stores and then district stores, then blocks, and then PHC and CHCs, which is like primary health centers and community health centers. So let's talk about even first, which started in 2014, which answers three critical questions. Where are my vaccines? Are they stored in adequate quantity? And are they stored in recommended temperature? So as you can see on your screen, how this entire ecosystem work. We empower all the cold chain handlers with a mobile application called Even, wherein all the healthcare workers working at the last mile can perform all the transactions which they are doing routinely, like issuing vaccine, receiving vaccines from higher store, doing physical count and then updating it. In case of any discard, reporting it. And also the digital order management system, wherein based on the stock level and the established minimum and maximum, System is capable of generating indent digitally, and it will also ensure that the optimum quantity is being dispatched from higher store to lower store. We also installed temperature loggers on all cold chain equipment which are meant for storing vaccines. And this temperature logger is a SIM based and Wi Fi based device, which is capable of sending temperature sample after every defined interval, like 1 hour, to the even cloud server. And once these transactions, these temperature samples are aggregated at the cloud server, then all the program managers sitting at district level, state level, national level can have real time visibility of vaccine stocks and storage temperature. Not just that, they can also see important reports like consumption reports, early expiry reports, uh, notifications in case of temperature alarms. They can see SOP reminders, and all sort of programmatic information is there on their fingertips. And this entire ecosystem is open source. So if I talk about the cost effectiveness of this entire ecosystem, in 2018 there was a techno-economic assessment done by Ministry of Health and Family Welfare, wherein it was concluded that over 19 million vaccine doses saved through even with a return on investment of 2.91. So, in a nutshell, if you spend or if you invest $1 on even, you will get a return on investment of around 3, which is 2.91 USD. And some of the best practices are that the Ministry of Health managed to reduce 75% of stockouts with this intervention. There are dedicated human resources at district level, regional level, state level for system strengthening. There are dedicated training modules, SOPs for all cold chain handlers. The activity rate and adherence rate is 99%. So when we say that we have close to uh, 29,000 cold chain handlers and healthcare workers, 99% of them do the entries in time. We record close to 7 million transactions every month by healthcare workers, and 20 million temperature samples are there every month from the temperature loggers. And the entire indentation process from the primary store till the last mile, last cold chain point is digitized. So, like Amazon, we can see the status of vaccines, where it is right now, how much is ordered, how much is shipped, and how much is going to be dispatched. So now in year 2020, when pandemic hit, Ministry of Health leveraged even platform and utilized it to develop COVID. COVID is winning over COVID, and there are certain guiding principles which was there, like and like there are certain assurance functions which has to be there. For example, there has to be a digital acknowledgement whenever you get vaccinated. Based on WHO norms, a QR code based certificate is generated. The doses interval minimum between first dose and second dose has to be maintained when you are digitizing. The vaccination schedule has to be consistent, and there has to be a verification and tracking mechanism from the system itself, that we can scan a particular QR code and get the information of the beneficiary, like at the airport or at the railway stations. And similarly, if you talk about the guiding principles, the system has to be equitable and inclusive, that people with ID card, without ID card, people at on-site or online will be able to register themselves and will be able to access the system, take appointment. It has to be a single source of truth. So it's not like we have 36 states and UTs and all of them are using different kind of MIS for coverage reporting. So COVID was the single source of truth for COVID vaccination in the country. And looking at the scale, we were supposed, I mean, we have to capture the data of 1.3 billion beneficiaries. The system has to be scalable, and it has to be, it should evolve. So the architecture has to be very sound. And there has to be a mechanism for feedback and analysis, for example, AFY reporting, and establishing a chatbot and a helpline kind of mechanism. So, as I told you before, uh, with the help of COVID, uh, Ministry of Health and Family Welfare in India managed to track more than 2 billion doses digitally, with 1.2 billion dose, 940 million dose 2, and around 170 million precaution dose. And more than 1 billion citizens got registered with the system. And 74% of these routine immunization sessions were in the rural part of the country. And as I mentioned earlier, more than 70% of doses were administered in the rural part, with 74% sessions happening in the rural areas. Uh, More than 740 million doses were administered through special sessions, like people without identity card, the prison inmates, near to home CVCs, COVID vaccination centers for old age citizens, and everything was happening digitally. And we also established a technical helpline, which managed to address more than 9 million queries. I mean, the queries were like how to download certificate, how to change the ID number, how to do minor corrections in the certificate, and all those kind of things. How to book an appointment. So, moving from pillar one to pillar two, and now talking about pillar three, which is UN. So, as we look at these three pillars at a glance, uh, I would like to re-emphasize that even Coven UN is more about governance, SOPs, and the human resource behind the technology. So it's not just technology; it's a equitable importance of people, process, and technology, which makes this system functional. Now, talking about UN and what was the rationale behind using this is 1.1 billion beneficiaries are already registered, out of which 530 million are females, which are in reproductive age group. So, which is again around 374 million. So, this data already exists in the system. Then we have around 250,000 vaccinators which are already registered, who are familiar with conducting online sessions and doing it well. And then the system is technically very sound. The architecture is very humongous and technically sound to manage these many databases. So leveraging this overall ecosystem, UWIN is developed, and UWIN includes a registration module to register pregnant women and children. If a female is already registered on CoWIN, she can be tagged as pregnant. There is a healthcare module for tracking and recording services like session sites, delivery, and other things. There's a delivery point module, which is used by the staff nurse to capture the pregnancy outcome and to register a newborn. There is a session planning module to conduct sessions, to open the sessions so that people can have a look at it and they can book the slots online. And lastly, there's a mobilizer module for ASHA workers, which is around 1 million in the country, accredited social health activist. And here the digital due list is generated and the ASHA worker can see the sessions happening in the country. So as we are talking, the UWIN pilot is already ongoing in India, and more than 1.5 million beneficiaries are registered. And during the intensified mission in the Dhanush campaign in India, UWIN is utilized as a single source of truth. Now, at the last, I'd like to talk about the learnings of this overall process. Now, in terms of governance, there has to be strong government ownership, which is there in even CoWIN and UWIN, as it's a single source of truth for reporting. And there has to be a dedicated and skilled human resource to operate these systems. and that's why the adherence rate is so high. And as I said earlier, it's not just technology. Building strong operating standard operating procedures is very important to operationalize such kind of systems. And of course, the review mechanism and the regular capacity building is very important when we talk about large scale digital health solution. So these are certain governance based learnings. And if you talk about the technical learnings, then now we have to move from traditional database to big data architecture. When we are talking about millions of people getting billions of doses, we need to have a very robust system in place. Uh, from licensed products to sustainable open source solution. When we talk about digital public good and digital public infrastructure, during recent G20 summit in India, DPG and DPI is the thing which everybody is favoring, and it is important for all to develop it responsibly. Uh, Interoperability between different systems like nutrition-based system, maternal health-based system, and vaccination is very important. So it's not just data triangulation, but open APIs for interoperability. And of course, complying with all the IT infrastructure when we are storing so much of data, complying to the security audits and all high-end security measures is very important. So I'll stop here, and I would like to thank once again to all the organizers and the Ministry of Health and Family Welfare, Gavi, and of course TechNet Conference for giving me this opportunity. And we'll be happy to take up any questions in whichever possible way it is. So thanks so much, and best wishes to all of you for the conference. Thank you.
Okay, we send our thanks to Abhimanyu for over a long distance. I hope he's watching on Zoom. Next, I will invite Stefano to share his learnings from the study he conducted across 4 countries.
Thank you. Good morning. Buenos dias. I know that I'm the last speaker before the closing remarks, so I'll try to be very brief and very focused as much as I can. At first, a couple of data points on the study that is behind the findings we're going to share in a second. Is a 4-country evaluation, programmatic and economic evaluation conducted in Honduras, Tanzania, Rwanda, and Guinea across 2 systems, ELMIS and EIR. We'll focus more on the LMIS component today, using a mixed method of primary and secondary data collection conducted by 6 partners, MMGH that I'm representing here, Bocconi University, and 4 in-country partners responsible for the data collection and analysis, under the oversight and technical support of Gavi and WHO, and the funding of the Bill and Melinda Gates Foundation. If we focus on the complex data and information flow and think about the digital transformation of supply chain that can result from the implementation of digital solution, 5 macro areas we found deserve special attention. Governance and existence of digitalization policies and strategies that across the 4 countries was available and influenced the decisions. The existence of a functioning infrastructure, particularly information and communication technology, and all the shortcomings and implications of those shortcomings that emerge from our study. The importance of the right hiring, retention, and training of staff, ultimately are people and health workers that operate the systems. As somebody said before, it's easy, relatively easy, to implement the system. It's much more difficult to make it operating and keep on operating. The whole big theme of data quality and data communication and data transmission that has components, of course, systemic components and technical components, but very many also change management and cultural components linked to that, and the linked use of data. and more technically and specifically, the intermediate step towards the impact on health outcome that in the specific case of ELMIS has to do with forecasting and vaccine management as a broader theme and area. So all those areas were studied, investigated. We'll be happy I mean, the information in the study will be available, so we'll be able to see the element that emerged from those investigations. But also following what Sachin said before, I would like to pick up one theme that to me is quite important and relevant. It is the theme of integration and two dimensions of integration: cross-system integration and cross-program integration. And both extremely important. And we saw some good results in the two countries that we investigated where those integration occurred. Cross-system integration was the case in Tanzania, where the two systems, Timor and VIMS, were eventually integrated in a unique and interoperable structure and ecosystem to allow capturing the performance of the immunization program and feeding that into the functioning of the logistic management system. In the relatively small number of health facilities and districts where this was functioning, there was indeed an improvement in the performance of the logistic systems, with a reduction from 3.8 to 3.2 stock out per year per region when we average a 3 year of the study. So having the connection between the immunization program and the logistic information and the logistic system that feed the immunization program does produce positive results. The other dimension of integration is cross-program integration, and here's the case of Guinea, where the decision was taken to implement one single system across all 14 health programs, starting from the Ebola crisis, then moving into malaria, and then expanding to other programs, including immunization. Here, I mean, it emerged very critical the dimension on the contribution to sustainability, both financial and programmatic sustainability, and governmental ownership. Here also the results were positive, with a reduction of more than 4% of the stock out, a statistical significant reduction of number of stock outs across 45 different health facilities over 4 years and over 3 vaccines, pentavalent, measles, and BCG. So integration can help across the entire data flow and information flow to deliver better performance and to have indirectly impact on health outcomes. Again, I promise I will not going to take much of your time, and I will conclude just by looking at 5 main recommendations. And for the one of you that were in the room this morning where we presented more details, I apologize for repeating those recommendations. But 4 main conclusions and recommendations we felt they are very relevant in general for digital tools and in the specific for electronic logistic management information system. The first one, very critical, that those tools need to be designed to meet programmatic needs, need to be designed to help the health worker at the last point of delivery. If that's not the case, that entire flow that we discussed before is not going to be activated. The data quality will be impacted. The utility of the system will be questioned, and ultimately decision will be taken not in the right fashion. This is not always the case. And linked to that design, intentionally looking at supporting health workers, should also intentionally target an end state of full digitalization. That is paramount for economic sustainability and for assisting healthcare workers not duplicating their work. We discussed about integration extensively before. A precondition that emerged very clearly as a critical precondition that, if not met, greatly impact the ability of those systems to deliver results is a functioning IT ecosystem across the board, functioning and financed IT ecosystem, and the availability of local human resources and capacity. Without those, I mean, even the best design system, again, I'm not saying anything especially new, but extremely important. Our recommendation was not invest if those preconditions are not met. And then 2 general calls for action that are extended also to many of the people in this room, and if we are not sitting in the countries. The need for implementation research to really understand the impact of the electronic tools. We did a study in 4 countries. Again, primary research was included into that, but the sample was not enormous. And many aspects, some not obvious, emerged We believe that there is a need of developing a broader understanding. There are other studies that has been performed. We are discussing with some colleagues this morning. Maybe there is a point in time now where we have sufficient study that can be pulled together to try to generate even broader set of common learnings, and really to understand one step beyond our ability of looking only the output in this study. We just look at output. We need to look one step further down to outcomes, looking at vaccination timelines, looking at the impact on coverage, and that ultimately lead to reduction in mortality and morbidity. And the last point, again, more directed to countries, in the spirit of empowering countries, of increasing ownership at country level. Monitoring and evaluation need to be included into the design of the implementation of those systems. It's the only way to let countries themselves uncover those findings, continuously uncover that, and providing a feedback loop that can influence implementation. It was great for us to work in these 4 countries to help them uncovering some of the insights, but our main goal ultimately was to hand over the study to the country and make recommendations that they perform in country the next evaluation. With that, I believe I've stayed within my timelines and I don't steal any more time.
Nicely done, Stefano. Let's appreciate them, please. Thanks. So we'll have about just 5 minutes for questions and quick feedback, and we would have to go to closing remarks. So, if Sachin, yeah, thanks. Questions, feedback? Gone once, twice. Really? Ranjit, and then Dorot.
I'm not sure if Abhimanyu is online. It's a question to him. What's the plan of expanding this to other countries, even?
Plan of expanding it to other countries.
Yes, thank you. I can just very briefly, because he would be the best person to answer, and I think he will be able to answer this offline. I will connect you to him. But the government of India has offered both EVIN, UVIN, and COVIN as open source code, and government of India as well as the partner UNDP are happy to support any country which wants to use that open source code and get into a digitalization project around any of those 3 systems. But of course, any country which is interested has to approach them, approach Abhimanyu, and they can take the discussions from there on.
Thank you, Sachin. I think this question is to you, and that was in an observation based on your presentation. You make the very important observation that the vision of digitalization is not something that should be restricted to pilot testing, right? Creating the innovation or the digital solution and then testing. But the big issue, and I think that this is the major failure of introducing digitalization in the health system or even supply chain, is the short-term vision for investing in this kind of innovation. So what would be your recommendation in this case? Because we are mostly facing the shortage of investment to go up to envision the digitalization from the design up to the sustainable phase.
So 30 seconds, Sachin.
I think most importantly, I think a lot of actors in this space, whether it's Gavi and many of our implementing partners, are helping the government and EPI program to take a more long term. These projects, all digitalization projects, you saw even the EVIN journey, it had started from 2015. Most countries you will see that it takes, even now that the implementation times are collapsing, but still, these are very long projects. What is important now also is that we have now starting to get different learnings from different where we can see benefits, and I think the Bocconi study also quantifies some of the benefits. So we can see that somewhere these projects are self-sustaining. You are actually saving money out of these, and that is what is helping to have more these conversations with governments, that even when the donor support or partner support transitions, they can continue to sustain these systems, and actually they will pay for themselves.
Thanks very much, Sachin. Let's appreciate all the panel members, Eric, Sachin, Stefano,